and he used some of my slides that I made for him, and now I'm giving this talk and I'm using some of his slides, so that's why his name is here too. So last week this was in Indiana, this week is we're in India, so that I think that's kind of funny. So let's go forward, and this is kind of an interesting slide. So this is what keeps me up at night, in addition to a baby that's gonna get born in a couple of months and a teenage daughter that I have. This is more keeping me up at night. So we have this disease, and it's called myopia, right? Something similar to utopia. And we have certain populations where children get, about 90% of children get this disease. Another population where 50% of children get this disease. And we know how to treat it, or how to, at least how to manage it, right? And we have so many methods, great methods that have been proven over and over again that they work. So there's no doubt that all of those work. So we have orthokeratology, we have multifocal lenses, we have atropine drops, we have time outdoors, we have some contact, some glasses that reduce the contrast. Every one of those works. Sometimes they work well together, sometimes they don't work, but generally they work. We don't know why they work. We have this disease that, I'm just gonna repeat this, we have this disease that 90% of children might get. We have a number of treatments or management methods that we know 100% that they work, 70% of the time, sometimes more, but we don't know why. So I'm not a doctor, I'm a physicist. So to me, physics being a very precise science, this is mind-boggling. Like, this would not, like, oh, I took an airplane here, I don't know anything about aerodynamics. The airplane flew, that's good enough. That doesn't work. So, and this talk is not going to be designed to explain why it works. This is too difficult. I'm hoping that some of the students that sit here will get some ideas. They will go home and go, I'm not going to sleep until I figure it out. So that's my hope. So my hope is that some of you will lose your sleep over this, just as much as a lot of the gurus that are sitting here have been losing their sleep for past probably 20, 30 years already. So let's go. And one of the theories that came up was the defocus, the peripheral defocus theory, right? So we are saying that there is the retina is reacting to the focus in the periphery, and since we have those multifocal lenses that have more plus, like basically center distance lenses, they have more plus in the periphery, we're focusing the light more in the periphery, and the eye stops growing. Well, this theory breaks down. So the theory was there because there's some research done with monkeys where their fovea was destroyed with the laser, and the only way they could get emmetropization is through the signal in the peripheral, the peripheral retina. So that's really good. We know how the emmetropization works, and most likely there is something in the periphery that helps the emmetropization. Emmetropization and myopia management are not exactly the same thing. So they probably have some similar mechanisms, but nobody has shown that they are similar. If we go back here, the fact that your lens has more plus in the periphery does not mean that the light that goes to the periphery focuses through the peripheral point of the lens. That's a misconception. The light goes through the entire pupil, and it focuses where it gets focused. So the peripheral light does not go through the periphery in the contact lens, because the contact lens is so close to the pupil. So that's so what we're and now if you look at some of the more advanced myopia control options from Cooper Vision and from Johnson & Johnson, you see that their designs are not those simple, center distance designs anymore. They have multiple rings, as this J&J lens with a very And again, multiple rings in the Cooper vision. So this, like, I'm gonna focus the periphery on the periphery of the pupil, and then the center does not work anymore. But we know that both of those lenses are very good myopia control options. So what Pat and I try to do is try to basically create a tool that would at least illustrate what's going on in the eye. So it will help people think about, okay, this is what's happening. Let me think about what is happening within the retina, within the physiology. Let's first of all figure out what happens with the optics. So we're using the ZMAX Optics Studio ray tracing software, and this is kind of an industry standard for designing complex lenses. So if you want to design a lens for a Nikon camera, there's probably some Nikon engineer somewhere using ZMAX. We have the simple eye model, which is the Atchison standard eye model. So we have a cornea, aqueous, we have a pupil. And for this presentation, all the pupils are 5 millimeters. We have a lens, which is a green lens. It has a gradient index of reaction change. And then we have a vitreous and the retina. So just the standard eye model. Then we go we will be tracing different rays. We will be tracing rays that go through the periphery of the pupil and through the center of the pupil. Here we'll have spot diagrams that basically shows what does the light look like on the retina. And we'll have modulated transfer functions, which is basically similar to a contrast sensitivity function minus all the psychophysics that happens in the eye. So this is the contrast sensitivity just from the optical point of view. 100 over there, that's your 20/20 vision. So whatever you get is the contrast that the optics gives you at the 20/20 stimulus. So for an emmetropic eye, we have a really nice small spot size. We have a pretty good modulation transfer function, and we have a little bit of spherical aberration. For a myope, we have the beams focus about 1 millimeter in front of the retina, and you have this huge spot, almost 300 micron size spot. Almost 300 micron size spot, and your modulation transfer function drops, so you don't expect to see anything, basically. If we put a 3 diopter contact lens, we get some spherical aberrations, and then we see them because some of the beams focus in front of the retina, some focus behind, so that's caused by spherical aberrations, and our spot size increases. If we put a spherical contact lens, we get beautiful, almost theoretically limited modulation transfer function. So it basically shows that aspherical contact lenses work better than spherical contact lenses, which we already knew. And we get a very small spot size and a very good, very small spherical aberrations. And then just for illustration, all those the high acuity happened at the foveola, which is about 350 micron size, right in the middle. So that's where the high acuity stuff happens. Like anything outside of that 350 micron is you're never getting 20/20 there. So now we can, with having those tools, with having ZMAX, we'll have the understanding of where the lights go. We can now look at what those lenses, the myopia control lenses from Cooper Vision and Johnson & Johnson, what do they look like? So if we look at the Cooper Vision lens, we have 2 rings basically. So this area, this green area, is your distance vision, and then you have 2 rings that are, so here is distance, here is your add power, here is distance, here is another add power. For some reason, this add power, if you're dealing with a 5 millimeter pupil, that does not contribute. That gets out of the pupil, that gets cut off. I don't know why it's there. Cooper probably had some reasons why they put it there. If we look at the ray tracing, so this is very close to the retina. So we have those peripherals, so that the light that goes here, that focuses in front of the retina, about 0.7 millimeters in front of the retina, and the light from the green regions, that focuses right on the retina. So that's what this lens does. Let's look at the MTF, so that's the modulation transfer function. This is a remarkably good lens. And for a multifocal, if you want to treat your presbyopic patients, this is a really good MTF function. Because every time you put a multifocal, you do some trade-offs. And some trade-offs work well, some trade-offs don't work well. I'm not getting paid by Cooper Vision. When I did this, I'm like, wow, they know something. You know? so yeah, this is what you would see if you were looking at the star far away. This is what you would see. You would see your star in the middle, and then you'll see the halos around it that come from your plus power addition rings. Now let's look at the Johnson & Johnson ability. They claim to have this kind of, so there's a question I don't know the answer to. They claim to have a +10 diopter at here, then distance vision, +7 diopter, and then distance vision. But when we measured it using an interferometer, this +7 diopter turned out to be +2 diopter. So I don't know which one is correct. I trust that measurement a little more. So when we trace that one, so we have this +10 power right in the middle. Technically, you wouldn't, I don't know why they put it there, because that's where you would, like, because it's a small pupil size, you would expect your best visual acuity, and they're basically saying, we're not gonna give you any signal from the middle of your pupil. We're just gonna cancel it, focus it in front of the retina, right here. So, this got cut off a little bit, but they're basically saying that, so whatever light comes from here, it's gonna get focused right here in front of the retina. So you're not even gonna see it. It's just gonna give you some blur, some background. And then we have those 2 millimeter highly spherical, the +2 diopter highly spherical parts, and your distance vision. And they're all gonna focus closer to the retina. So when we look closer, we get those far dots. They basically create some sort of a blur background, probably similar to your glasses with those lenslets. And then you have this aspherical spot in the middle that gives you a really good vision. And then you have those 2 diopters with those peaks, so that's kind of extended depth of focus diopters. So when we look at the modulation transfer function for this one, I don't. But this also works pretty well. I don't know why. I mean, there's some magic there, but this one also works pretty well. Do I have a few more minutes? Yeah. So, but the other question is, like, we know that lenses decenter, and there is some evidence, although, that decentered lenses provide better myopia control signal. Although at Vision by Design about a month ago, Maria Liu from Berkeley claimed that data needs to be revisited because of some biases in the way that data was collected. So right now, if you ask somebody, they will say, okay, yeah, decentered lenses are better, but let's question that. Let's not take it as a 100% value. So that theory is being questioned right now. Why do they decenter? Because there is any contact lens, any soft contact lens that is not designed to not decenter will decenter, because there is a difference in the elevation. I think that's very standard for eyes. There's a difference in the elevation between nasal and temporal. So if you imagine you're putting something down, it's gonna slide down towards temporal. So basically, you're just, and then that's what happens with the eye right there. We can also model decentered lenses, and then when we're modeling decentered lenses, we are seeing that things break down even further. So this one is, which one? Oh, so this one is my Johnson & Johnson lens, and so this is the nice spot diagram here. That's my Landolt-C. It's simulated Landolt-C. I decentered the lens by 1 millimeter, and the Landolt-C, I mean, you can see that the quality of vision drops, and your the spot diagram also gets wonky. One of the theories, so there, I talked about this, the theory about the peripheral, the basic peripheral defocus. The other theory is this like dueling, conflicting images that happened on the retina. So you basically have one image on the retina and then the other image on the retina, and the retina is trying to get confused, the accommodation goes back and forth, it gets confused, and then that stops the eye from growth, right? But, and we can see that here because we have one focus, another focus. When we decenter the lens, that kind of falls apart as well. So we need to revisit this, look at it more closer, and understand what happens to the optics. Does that defocus, basically the dueling defocus image, does that still work when you decenter the lens? Maybe it does, maybe it doesn't, I don't know. When I look at the ray diagrams, this I can see being a dueling image. This I just see a bunch of spots in the random order. So, the summary is boring because I already told you what I think. I mean, I think that there are two reasons why we do this. So reason number one is trying to understand what is happening in the eye, and then this is the reasons. So for hopefully some of you, to some of the younger ones, to go home and lose sleep over this, because this is a fascinating topic. And then the second reason is that what we can do now, especially with scleral lenses, is we can model the optics to a particular eye. So we now have the technology to say, I have this eye, the eye shows like it has this much axial length, it has this much power, the pupil is positioned here, it's this big, let's make the wavefront on the retina the way we want to do it. So we now have that capability. What we don't have is the understanding of what we want to put on that retina for that child's eye to stop growing. So that's the $10 billion question. So, and that's that for me.
Thank you so much. Just one more question. All those, can you go back to one slide? So that's a theoretical centration or the real?
This one?
No, one more. Go front. No.
More?
Yes. So the first slide is a theoretical thing.
Yeah. So this is model.
Yeah.
So
in reality, when you put a soft contact lens, it doesn't. Of course, it will center, but what about the horizontal? Because the angle kappa.
Oh, so that is so it is moved in one direction. So it's only moved in. So I only modeled the horizontal in one direction. So yeah, this is.
So we still have a lot of things to work on, and as I said, a lot of people are losing sleep overnight for the what exactly we are looking for. Thank you so much for waking us up. Thank you so much. Who's the next?
Nishant.
Let us invite Dr. Nishant Tambe and go back to some cataracts and how to manage astigmatism. I have purposely asked him to make it more simple so that most of us can understand.
थोडं वेळ